He felt fine. That was the thing nobody could explain. He had mowed his lawn that Saturday morning, eaten breakfast, and sat down in his favorite chair to watch the news. By evening, something had changed. He could not quite find the word he was looking for. His right hand felt heavy. He laughed it off, said he was tired. His wife noticed something in his eyes she had never seen before and could not name. By Monday morning, the neurologist was showing them a scan. There it was, a silent stroke. Evidence of an event that had already come and gone while he sat in that chair, feeling perfectly fine. This happens more than you know. And the part that should keep you up at night is not the stroke itself. It is the 5 days, 5 weeks, sometimes 5 years before the stroke when the triggers are already running, already building pressure inside the vessels of your brain, and nobody has told you what they are or what to do about them. Stay with me, because by the time you finish this video, you will know exactly what those triggers are, why they hit harder after 60, and what you can do starting tonight to interrupt the chain before it reaches the point of no return. Here is what nobody tells you. Silent strokes do not announce themselves. They do not come with the dramatic warning signs you have been trained to recognize. No sudden paralysis, no slurred speech that brings the ambulance. They come quietly. They damage quietly. And they leave you standing in your kitchen 3 years later wondering why you cannot remember where you put your glasses, why you feel foggy before noon, why you are not quite yourself, without ever knowing there was a moment when your brain was starved of blood and something inside it permanently changed. The medical community has a term for what accumulates after repeated silent strokes: white matter lesions, small scars on the brain. And the research is sobering. People over 60 who have experienced silent strokes, often without ever knowing it, face a significantly higher risk of a major stroke, cognitive decline, and problems with balance and coordination that increase fall risk dramatically. One study tracking adults over 60 found that nearly 1 in 3 showed evidence of silent cerebrovascular events on MRI imaging. 1 in 3. And most of them had no idea. My name is Dr. Elias Harmon. I am a cardiothoracic surgeon. I have spent 31 years in operating rooms. I have performed over 2,000 open heart procedures. I have held beating hearts in my hands. And I will tell you something that took me years to say out loud. The most dangerous moments in cardiovascular health do not happen in the operating room. They happen in the living room, the kitchen, the bedroom, in the ordinary hours of ordinary days, when triggers that nobody has explained clearly enough are doing their silent work inside your body. The reason I am standing here talking directly to you, instead of writing another paper for a journal that will sit unread in a database, is because I have watched too many people arrive at crisis points that were preventable. I have had too many conversations with families in waiting rooms where the right information, delivered at the right time, would have changed everything. The medical system is extraordinary at crisis intervention. It is far less extraordinary at prevention education. And that gap has cost people dearly. So let us close that gap right now. After 60, the body is not the same vessel it was at 40. You already know this in the way your joints feel on cold mornings, in the way recovery takes longer, in the way sleep is different than it used to be. But what most people do not understand is what is happening specifically inside the brain and its blood supply as the decades accumulate. Think of your cerebral arteries as a garden hose system. For 60 years, pressure has moved through those hoses. Minerals have deposited on the inner walls. The walls themselves have lost some of their elasticity. The diameter of some of those hoses has narrowed. The pressure required to move adequate blood through them is higher. And the brain itself has become more sensitive to fluctuations in that blood supply, less tolerant of interruptions, less capable of compensating when flow drops suddenly. At 60, the brain's ability to auto-regulate, to adjust blood flow in response to changes in pressure and position and activity begins to decline. The margin for error gets smaller. What the body at 40 could absorb without consequence becomes, at 65 or 70, a trigger for a cascading event. That is not pessimism. That is physiology. And knowing it means you can work with it instead of being blindsided by it. Here is the first trigger, and it is so ordinary that most people dismiss it immediately when they hear it. Dehydration. Not severe dehydration. Not the kind that sends you to the emergency room. Chronic mild dehydration. The low-grade kind that settles in over weeks and months when fluid intake quietly drops below what the body needs, which happens far more commonly after 60 than at any other stage of life. The sensation of thirst becomes less reliable. The kidneys become less efficient. Medications that many people over 60 take, including common blood pressure medications and diuretics, compound the problem. And the blood becomes more viscous, thicker, slower moving. In a narrowed cerebral artery, slow, thick blood is not a trivial problem. A small clot that the body might dissolve easily in a well-hydrated person can become a blockage in a dehydrated one. Slow flow means platelets have more time to aggregate, more time to stick to damaged vessel walls, more opportunity to create the kind of microclot that causes a silent stroke without ever triggering a visible symptom. The research on hydration and stroke risk in older adults is consistent and often underreported. Studies have shown that even a 2% reduction in body water content measurably increases blood viscosity. And blood viscosity is one of the less discussed but critically important variables in cerebrovascular risk. What does this mean specifically for you? Not a glass of water every now and then when you feel thirsty. Write that down. A consistent intake of water across the entire day, front-loaded in the morning before the blood has thinned from overnight dehydration that happens every single night regardless of what you drank the evening before. Starting tonight, keep a glass of water on your nightstand. Drink it before your feet hit the floor. Then make a rhythm of it through the day, small amounts, consistently, before meals, between activities, not juice, not coffee as a substitute, water. What is your relationship with hydration? Have you tracked how much you are actually drinking in a day? Leave that in the comments. You will surprise yourself. The second trigger has a name that sounds manageable and is anything but atrial fibrillation, AFib, an irregular heart rhythm that affects an estimated 9 million Americans over 65, according to figures from the American Heart Association. And here is the part that connects directly to silent strokes. A significant percentage of AFib episodes produce no symptoms whatsoever. No racing heart, no palpitations you would notice, no dizziness. The heart simply fires in an irregular pattern for minutes, hours, sometimes days, and during that time, blood pools inefficiently in the chambers of the heart and clots can form. When the rhythm restores itself, those clots can be released into the bloodstream and travel directly to the brain. Silent AFib producing silent strokes, two invisible events compounding each other inside a body that feels, to its owner, completely fine. The technology to detect this exists and is increasingly accessible. Wearable devices now exist that can identify irregular heart rhythm patterns over time, and cardiologists can conduct monitoring over extended periods to catch intermittent episodes that would never appear in a standard 12-second EKG performed in an office. If you are over 60 and you have never had an extended cardiac monitoring evaluation, that conversation with your physician is worth having. Not tomorrow, this week. And here is what I need you to hear between those two items before we continue. The first two triggers share something important. They are often invisible in the moment. No pain, no alarm, no signal that something is building. The stroke risk that accumulates from chronic dehydration and undetected AFib does not come with a warning label. This is precisely why the next three triggers matter as much as they do. Because the window to intervene is open right now. For most people watching this, it is still open. But that window does not stay open indefinitely. Stay with me. The third trigger is one that the medical community has been slowly recalibrating its understanding of for the last decade, and the revision is important enough that you need to hear it directly. Blood pressure. Specifically, blood pressure fluctuation, not just high blood pressure as a static number, but the variability of blood pressure across the course of a single day. For years, the clinical focus was on getting the average number down, and that matters. But emerging research has identified that visit-to-visit variability, meaning the pattern of blood pressure rising and falling significantly across days and weeks, is an independent risk factor for silent cerebrovascular events, separate from the average reading itself. A person whose pressure swings between 120 and 160 over the course of a day may face higher stroke risk than someone who maintains a steady 145, even though the average might look similar on paper. After 60, blood pressure becomes inherently more variable. The arterial walls are less elastic. Blood pressure rises quickly when you stand up quickly after sitting. It drops when you are dehydrated or have not eaten. It spikes during moments of acute stress that your body processes differently than it did at 40. And those swings, those moment-to-moment and hour-to-hour fluctuations, represent repeated mechanical stress on vessel walls that are already compromised by decades of use. Here is what specifically to do. First, if you are monitoring your blood pressure at home, do not take it once in the morning and consider that data sufficient. Take it at different times across the day for 2 weeks and bring that record to your doctor. The pattern matters more than any individual reading. Second, discuss with your physician whether your current medication regimen is smoothing out fluctuations or potentially contributing to them. Certain blood pressure medication timing strategies are specifically designed to reduce variability, and not every prescribing decision accounts for this. The fourth trigger is one that will surprise many people because it does not sound like a cardiovascular issue at all: sleep-disordered breathing. specifically obstructive sleep apnea, OSA, which affects a substantial proportion of adults over 60 and remains one of the most underdiagnosed conditions in the older adult population. During an apnea event, breathing stops, oxygen saturation in the blood drops. The brain, which is extraordinarily oxygen dependent, registers this as a crisis and sends a sharp hormonal signal that briefly spikes blood pressure and heart rate to compensate. This happens repeatedly through the night, sometimes dozens of times per hour. What this means for cerebrovascular health is significant. Each apnea event creates a microstress on the cerebral vasculature. Each oxygen drop reduces the brain's tolerance margin. Each nighttime blood pressure spike stresses vessel walls that are already carrying the load of years. Over months and years, untreated sleep apnea creates a cumulative damage profile that substantially increases both silent and symptomatic stroke risk. The classic symptom is loud snoring with pauses, but here is what nobody tells you. Many people with sleep apnea, particularly women and older adults, do not present with classic symptoms. They wake feeling unrefreshed. They experience morning headaches. They feel foggy in the first hours of the day. They have higher than expected nighttime urination. None of these individually point clearly to sleep apnea, which is why the diagnosis is often missed for years. A sleep study, either in a lab or with a home monitoring device, is the only way to know. If you have any of the symptoms described, that conversation needs to happen with your doctor. And for those who have already been diagnosed and prescribed a CPAP device that sits gathering dust in the closet, I am speaking directly to you. The evidence on CPAP compliance and reduced stroke risk is substantial. That machine is not optional equipment. The fifth trigger is where the science meets something I find almost unbearable to discuss professionally because it represents a category of harm that should not be happening in the era of medicine we are living in. Poorly managed blood sugar and prediabetes in older adults, not just diagnosed diabetes, prediabetes, a condition that, by current estimates, affects more than 1 in 3 American adults over 65, and of which the vast majority are unaware. Elevated blood sugar over time, even at levels that do not yet meet the clinical threshold for a diabetes diagnosis, damages the endothelium, the inner lining of blood vessels, including the tiny, delicate cerebral vessels that supply the deepest structures of the brain. The mechanism is direct and well established. Elevated glucose creates inflammatory changes in vessel walls. It promotes the buildup of material that narrows vessel diameter. It impairs the blood's clotting regulation in ways that increase both clot formation and unpredictable bleeding. And because the brain's smaller vessels are among the most vulnerable to this kind of damage, the cerebral microvascular impact of chronically elevated blood sugar is one of the most consistent findings in silent stroke research. A fasting blood glucose test and an HbA1c, a 3-month average blood sugar reading, are routine labs. If yours have not been checked recently, that is the first specific action to take. If your numbers are in the pre-diabetic range and you have been told to watch your diet without specific guidance, that is not adequate. There are now well-established dietary and activity interventions that can reverse prediabetes in a significant percentage of cases when applied consistently. Ask for a referral to a diabetes prevention program or a registered dietitian who specializes in metabolic health. This is not a lifestyle suggestion. This is a stroke prevention strategy. I want to tell you something from inside the operating room. I have performed procedures on hearts that carry decades of damage from processes their owners were never told about in time. I have stood in operating suites at 2 in the morning and thought about families in waiting rooms who came to that moment through a path that included years of elevated blood pressure, years of undetected AFib, years of unmanaged blood sugar, years of quiet dehydration. And I have walked out to those families afterward and sat with them in silence that I still carry. The ordinary habits of daily life are not separate from cardiovascular health. They are cardiovascular health. What time you drink water in the morning. Whether you sleep through the night with your oxygen saturation dropping 40 times per hour or not. Whether your blood sugar is running at 96 or 112. These are not small details. These are the variables that determine what happens inside the vessels of your brain over the next decade. I do not say this to frighten you. I say this because this information has the power to change outcomes, and you deserve to have it directly. That question has stayed with me throughout 31 years of surgical practice. Not the technical question of how to repair damage once it exists. The deeper question of how much of that damage could have been interrupted earlier if the right people had access to the right information at the right time. I believe the answer is more than we want to admit. I want to tell you about a woman named Margaret. She came to my clinic at 68 after her primary care physician flagged an irregular reading during a routine appointment. She had no symptoms. She felt fine. Her monitoring revealed paroxysmal atrial fibrillation. When we did additional workup, we found evidence of prior silent ischemic events. We started anticoagulation therapy, addressed her sleep apnea, which she had not known about, adjusted her blood pressure management to reduce variability, and worked with a nutritionist to bring her fasting glucose from 114 down to 91. 14 months later, she came back for a follow-up and sat across from me and said something I have repeated many times since. She said that she had spent years feeling slightly less herself and assumed it was just aging. Nobody had connected the dots for her. She said she wished someone had handed her this information at 55 instead of 68. Write that down. Because Margaret is not unusual. The experience of slowly feeling less sharp, less energetic, less fully present, and attributing it to the natural passage of time, rather than recognizing it as the upstream signal of something specific and addressable, is one of the most common stories I hear. Within 14 months of specific targeted intervention, Margaret had reduced from 4 medications to 2. Her cognition testing had improved measurably, and her cardiologist described her vascular profile as significantly stabilized. It is never too late. Let us bring this together now, because everything you have just heard is only as useful as what you do with it in the next 24 hours. The 5 silent stroke triggers after 60, and what to do about each of them starting tonight. 1. Chronic mild dehydration thickens the blood and slows cerebral circulation. Begin tonight with a glass of water before sleep, and one immediately on waking. Build a consistent rhythm of small fluid intake throughout the day. This is not a suggestion. This is a direct stroke risk reduction strategy. 2. Undetected atrial fibrillation allows clots to form and travel to the brain without warning. If you are over 60 and have never had extended cardiac rhythm monitoring, schedule that conversation with your physician this week. If you have a wearable device that tracks heart rhythm, use that data and share it. 3. Blood pressure variability, not just high blood pressure, stresses cerebral vessel walls repeatedly over time. Begin tracking your blood pressure at different times across the day. Bring the full pattern, not a single morning number, to your next medical appointment. 4. Untreated sleep apnea creates repeated nighttime oxygen drops and pressure spikes that damage the brain's smallest vessels over time. If you wake unrefreshed, have morning headaches, or your partner has noticed breathing irregularities during sleep, pursue a sleep evaluation. If you have a prescribed CPAP that you are not using, this is the moment to recommit to it. 5. Elevated blood sugar, even in the pre-diabetic range, damages the lining of cerebral vessels directly and measurably. If your fasting glucose and HbA1c have not been checked in the past year, that lab work should be your immediate next step. Now here is what I want to ask you. Which of these 5 surprised you most? Or has something in your own health history come to mind as you watched? Leave that in the comments below. Not for me. For the person watching after you, who may see their own situation in your words and take action they would not have taken otherwise. That kind of community matters more than most people realize. If this reached you at a moment when it was useful, share it with someone over 60 in your life. A spouse, a sibling, a friend. You do not need to explain it. Just send the video. The information will do the rest. And if you want the next video in this series, covering what happens inside the brain immediately after a silent stroke and what the earliest recovery window looks like, subscribe and you will see it the moment it is available. Your heart has been working for you every single minute of every day you have been alive. You owe it the best information you can give it. One final word before we close. Everything discussed in this video is intended as education and is based on published research and clinical experience. It is not a replacement for your relationship with your own physician who knows your complete medical history. Please use this information to have better, more specific conversations with your healthcare team, not to replace those conversations. Individual medical decisions should always involve a qualified provider who can evaluate your complete clinical picture.